You can never quantify how good sex was with a stopwatch. I want to be great, I want to win, I want to be awesome. But I think that sets up this issue where premature ejaculation, duration of sex before ejaculation becomes so central to many young men in particular, but men of any age, where the notion is that if I last long enough, if I just keep, pounding away, eventually she'll get there, and that's what defines me as a sexual being.
And I think the huge misconception is that longer penetration means better sex, which is absolutely not the case. Most women don't orgasm through vaginal penetration alone.
Let's expand that repertoire with the couple so that the sexual experience is much more than penetration. So where is that noisy, fun, loud vagina? Like maybe that's in penetration, maybe that's not in penetration, maybe that's in manual stimulation, oral stimulation, maybe that's with toys.
Yeah, I think almost half of premature ejaculation patients have some anxiety component involved. If you're not addressing those things, I think you're really doing the patient a disservice. We always have to make sure that we're treating erectile dysfunction because they're really worried they're going to lose their erection before they orgasm. So what do? They rush to the finish line.
Most men will tell you their top 3 favorite things about sex are penetration, penetration, and penetration. But the reality is that this narrow definition of sex might actually be creating one of the most common sexual concerns men face. I'm Dr. Rena Malik, urologist and pelvic surgeon, and welcome back to the Rena Malik MD podcast, your trusted guide for leveling up your health, relationships, and sex life with evidence-based tools. Today, I'm joined by 3 leading experts in men's sexual health. Dr. Alan Shindel is a professor of urology at UCSF in the Male Reproductive Health Division, a leading voice in sexual medicine internationally. Dr. Justin Dubin is a board-certified urologist and director of men's sexual health at Baptist Health in South Florida. He's also the co-host of a popular men's health podcast, the Man Up Podcast. Dr. Chris Nelson is the director of the Walther Center for Supportive Oncology at Indiana University and an internationally recognized leader in psycho-oncology research, specializing in cancer-related sexual dysfunction and survivorship challenges. Together, we're diving into premature ejaculation, a condition that affects up to 30% of men at some point in their lives, but is widely misunderstood by both patients and partners. We're covering the biology behind why some men ejaculate quickly, the psychological factors that make it worse, and what actually works for treatment, the surprising role of communication and relationship dynamics, and why everything you think you know about lasting longer might be wrong. This is a conversation about redefining what good sex actually means and how to help if you're struggling with lasting long enough in bed. Thank you guys so much for being here.
Thanks for having us.
So, the most common Google search is how long should sex last? So, let's talk about it. How long should sex last?
Well, I think it should last long enough that every party involved in sex ends the experience feeling satisfied, that their needs were met, that they had a good, enjoyable experience, they didn't feel like they missed out on anything that they were really hoping to have, and also hopefully having a feeling that they gave something to their partner in return. Now, obviously, we talk a lot about orgasm and ejaculation being an end goal, and for many men in particular, that is an end goal. For many women, also an end goal. I don't think it's a necessity necessarily for people to have an orgasm during sex, as pleasant as it is, because sex, as you know, involves lots of different rewards, different things people get out of sex. So ultimately, there's no ultimate universal answer to that question. It's what do you want it to be this particular time versus the next even.
Yeah, and I think that the real issue is there's like a misconception about like it should be a certain time and I should be reaching this, we should be going all night. And I think the reality is that sex doesn't really last that long if you look at the data, right? It's much shorter than what most people think.
Yeah, it's about 4 to 10 minutes, 3 to 7 minutes is around kind of like the sweet spot that we see in a lot of the literature. But what I found interesting, and I think we all think about that a lot of men don't think about, is, and not to be punny here, but we have to think outside the box when it comes to sex, right? Most men, when they were questioned in a survey, do not consider oral sex as sex. They don't consider manual, heavy petting, deep kissing as part of sex. And especially if anyone's struggling with premature ejaculation, when we're talking about strictly penetrative intercourse for most of these guys. Obviously, some of them, unfortunately, do ejaculate before they're even able to get to that point. But I think that especially for these guys and for all men, we really need to make sure that we're not just talking about penetration. We're talking about all forms of sex, because most women also don't achieve orgasm just through penetrative sex. So I think when you're talking about our goals, I think it's important that we are oftentimes thinking about the women and what they consider sex, what we consider sex, and how we can work together. And it all comes down to communication at the end of the day.
Yeah, and I think it's so true. And if you think about, like, okay, if you're defining sex very narrowly as penetration and penetration to orgasm, you get in that time frame that you talked about. And, but the notion of expanding the scripts, right? Expanding what a sexual relationship, what that concept is. And so I think part of the difficulty for men, of course, is if, when I'm talking with patients about this, right? And I say, like, okay, if you ask men kind of what is their favorite thing about sex, like what kind of top 10 list, right? Men will say, number 1 is penetration. Number 2 is penetration. Right? Number 3 is penetration. Right, and maybe down the list you get to orgasm, right? And then maybe kind of somewhere between 5 and 10, there's maybe things like intimacy or closeness or manual sex or oral sex or those things, right? And so, but if you ask women what their favorite things about sex are, it's almost just reversed, right? So women will say things like intimacy, closeness, togetherness, those types of things. And so, we have to think about and conceptualize men and women approach sex differently. And so what does it mean? So, like, how long is sex supposed to last, right? Well, boy, if it's so narrow and it's penetration orgasm, well, then we have maybe some time frames, right? But this notion, like, Ellen was talking about, is how do we expand the concept of what a sexual experience means, right? Where we're thinking about both partners, right? If there's 2 people or multiple people or one person in that experience, right? You're thinking about kind of all those involved and what does it mean for enjoyment for them. And so it really is this tricky question about, like, how long is sex supposed to last?
I would boil it down to say that perhaps you can never quantify how good sex was with a stopwatch.
Yes.
You'll never be able to define it like that. It's like it was this long and therefore it was good.
Right, and I think the huge misconception is that longer penetration means better sex, which is absolutely not the case. Most women don't orgasm through vaginal penetration alone, and I think I wonder if, yes, if you ask men, they say penetration is the most exciting part, but, like, if they really thought about it, would they really still say that? Like, is there, and I don't know, like, they're just thinking, like, that's the ultimate, because it's been so, like, put on a pedestal, like, this is the best thing about sex. But if they really think about it, is that really the best thing about sex for them?
Can I expound on that a little bit?
Absolutely.
Because I have some thoughts, and indulge me a little bit for some time here. I'm married to a gynecologist who is a specialist in women's sexual function. I've had a lot of conversations with her, and listeners to your podcast might know what that means. My conversations with her have been very informative, and it's some things I already knew, but hearing it from her perspective and hearing her experiences as a woman, someone who's been studying sex for a long time, she tells me about her college sexuality courses. There was a course on women's sexuality, which is very much about exploration of self, learning what you like, learning what you don't like, learning how to say yes or no, how to communicate about it. And it was very much about the individual experience of the woman, and that was what she learned in that. She took a course on men's sexuality, and what was fascinating to her, and the thing that she learned from that, was how much men were fixated on their partner experience. How can I make her orgasm? How can I make her feel good? How can I make her want more? How can I, do this well? And there's perhaps an altruistic element to that. They want to be good for their partners. There's also men being men. There's a competitive aspect. I want to be great. I want to win. I want to be awesome. I want people to look at me as this great lover. So there's a self-aggrandizing component to that as well. But I think that sets up this issue where premature ejaculation, duration of sex before ejaculation becomes so central to many young men in particular, but men of any age, where the notion is, and like you had said, the misconception that penetration leads to orgasm in women. And the notion that these young men have is that if I last long enough, if I just keep pounding away, eventually she'll get there, and therefore I have to last a long time because I want to be an awesome lover, and that's what defines me as a sexual being. How good am I at making my partner feel good? And that's kind of the genesis, I think, and there's more to say about it. I'll stop now, but there's more to say that will come out during this conversation, I think, about how that informs so much of the anxiety men have, and how it informs how often you see this quoted in literature that we've all read. Premature ejaculation, the most common male sexual function. 30% of men are premature ejaculators, going back to the 1999 publication by Ed Lauman from the National Social Life survey saying that 30% of men were premature ejaculators. Well, that was based on a single self-item report that at some point in the last year, the man had ejaculated before he wanted to, which is obviously not clinical premature ejaculation as we define it now. But it gets again at that notion men want to last longer, in part due to some misperceptions about what makes good sex.
Yeah, and I would say that I think it's similar on the female side. They want their partner to last longer because they don't realize that's not why they think that will make them orgasm if they're not having orgasms during sex.
Misperceptions on both sides.
Yeah, and so then it becomes this like pressure, like, oh, if I want to have a good orgasm, my partner has to last a certain amount of time, and that's not true for most women actually. So yeah, I think it's on both sides.
Well, and if I could just comment, I think the education around it, right, is so important because, your question, like, if men really think about it, right, is sex more to them than penetration? I'm not sure that, I'm not sure how many men would get there, right?
I'm wondering. I don't know. It's a question, right? I don't.
It's just, and Alan's point is like, is so true. This concept of, boy, I need to last so long. I need to be, I need to be kind of this particular type of lover. And like women will have an orgasm if I'm a great lover in penetration, right? That concept, I think, is just is so ingrained in kind of the male sexuality that the education piece, right? The talking about a piece, the working with your patients and explaining these aspects is so important. When I talk with men about this, they look at me like, "Whoa, really?" Yeah, and so it's important to bring up the conversation, right? And hopefully, kind of as we continue to talk, we can talk about the communication between partners and kind of the importance of what that means in a relationship and how to improve the sexual relationship with a couple.
Absolutely. How do you guys think porn is playing a role in shaping these thoughts that people have about how long sex should last?
I mean, I think that I personally don't think it's actually the porn. I think it is how people perceive their usage of porn, right? So there's not really been any strong literature suggesting that porn association with porn usage and premature ejaculation. But there is data showing, if you feel guilty about using porn, creating some kind of anxiety or depression around your habits, I think you have a good chance of creating a problem sexually, whether it's erectile dysfunction, premature ejaculation, delayed ejaculation. And I think as a society, we're probably making it worse by having people say, you're doing something bad. And if you're telling someone that they're doing something bad, even though they enjoy doing it, they're going to feel bad about it. And there's this conflict in your psyche, and there's a conflict sometimes with relationships. Some partners think that you're cheating because of these things. Some partners think that that's the cause. We're, creating a conflict within the relationship. So I don't think it's the porn, but I think it is the attitudes that we bring towards our usage of it and the attitudes we bring as a society, unfortunately, putting on people.
Yeah, absolutely. And I think it is, especially now on days of social media, like there's so much judgment that's easily given because you can be anonymous behind a computer screen and say, oh, porn is horrible. But the reality is the majority of people, a large majority, have watched porn or watch porn regularly. So it's very easy to try to make people feel like you're so morally superior because nobody knows who you are or you're behind a screen or whatever. And the reality is everyone is likely participating. Yeah. So when we're talking about premature ejaculation, how you mentioned like people just sometimes feel like they don't last long enough, but when does it become a real clinical diagnosis?
The guidelines on this have been revised many times. Just for some historical context, going back to the Masters and Johnson days, they defined it, revolutionary sex researchers, that it was if a man ejaculated before his female partner climaxed, 50% of the time or greater, that was premature ejaculation. Which is obviously an interesting definition. It's somewhat female-centric, which is nice. It is also putting the entire issue of is this long enough entirely on a partner who, again, may or may not climax from penetration. Not really a very fair definition, but one that came up, and obviously all respect to Masters and Johnson. It's evolved over time, and I think the central components of the definition, as they currently stand across most major definitions, including the Diagnostic and Statistical Manual by psychiatrists, the AUA definition, the International Consultation on Sexual Medicine definition, ICD-11, the unifying three central themes are lack of sense of control, meaning that the man does not feel he can really control, to any extent, exercise control over when he climaxes. Bother, primarily by the partner, or by the man, but sometimes by the partner too, and there's more to expound on about that later in this conversation. And most importantly, some sort of time-based criteria, because some of the older DSM-type definitions didn't have a time criterion. So you could have someone who had a latency time, from penetration to ejaculation of 20 minutes, who still met the criteria. And if you look at normative data, the median time between penetration and ejaculation is about 5 minutes in Western countries where we have the data. So clearly 20 minutes is not what most people would consider premature by any standard. So the time-based criteria as they currently stand, there's a little bit of variance here, but it's typically 2 minutes or less. So to kind of summarize it all, the fundamental criteria to meet a clinical diagnosis of premature ejaculation would be bother, lack of control, latency time 2 minutes or less. Oftentimes 1 minute or less is where most of those men fall.
Yeah.
Yeah, but I think there's something also to consider, and I think it's important. There's two different versions, right? So you really have the acquired, and then you have the version that you were born with, right? Some people come in and they say, hey, listen, I've had premature ejaculation. I'm 30 years old. I've had it since I started being sexually active. I ejaculate in 1 minute and 30 seconds. And then you have people who come in, they're 55 years old, hey, or they could still be younger and say, hey, I've usually last about 7 minutes, and now I'm lasting about 4 minutes. It's creating a lot of stress for me. And by definition, it typically is not really premature ejaculation, but something's changed. And I think I still at least treat those as some form. Of course, there's education saying, hey, listen, you were going 20 minutes before, now you're going 10 minutes. That's still pretty good. But if it's creating you a lot of anxiety, a lot of stress in your life, let's make sure that there's nothing else going on. Because oftentimes in the acquired, there's the question I'm always asking is, what's changed? Okay, so, it started a year ago. Did anything in your life change? Did you notice things that changed? Has anything changed? Because as we know, sexual health is really a window into our overall health. So I'm always looking for some kind of change in your health patterns, whether it's mental, physical, hormonal, that can be addressed in that visit.
Yeah, you're spot on that there's ultimately clinical judgment.
Right.
Patient bother are what dictates whether you treat or not and how you treat, of course. And the AUA definition, to expound on it a little bit, for the acquired type, which there's not as much data, most of the research is done on lifelong. For the acquired type, we did articulate that if it was a reduction by about 50% or so, which is about what you were quoting right there, and that can certainly be distressing. It can cause enough bother to a man who's experiencing it that, it still probably merits some sort of treatment if that's what the man decides he wants to do.
Yeah, and it's that, that distress piece, right? That's pivotal. And so I've certainly seen men who have said, like, this is my normal time. Maybe it's a minute and a half. And I have a number of partners where it's never been a problem. Like, we've enjoyed our sexual relationship and our sex life, and then so I have a new partner and she's really upset about it. No, I'm upset about it. And so that distress piece kicks in where this patient probably didn't even think that they had a concern or problem beforehand, but it's the communication, the relationship, and how that sexual relationship plays out.
Can I ask you guys a question? How many times do you have a partner come in for premature ejaculation? Because just going back in my head when we're talking about communication, for fertility, erectile dysfunction, obviously, I think a lot of the times the partners are with them. For premature ejaculation, I really can't think of one time where a partner has come in. I don't know about you guys.
I would agree with that. And if I can expound a little bit more, one time, Chris Nelson and I have known each other for a very long time, 20 years now, more. And our initial getting to know each other, we participated together in a study on infertile couples, invoking a few of these things. And I added my site to his, and we included some metrics of premature ejaculation, so assessing ejaculation and premature ejaculation in infertile couples. So it's a subset of the overall population. But what was interesting about it, and I think this has been borne out on multiple studies, is that we surveyed both partners of the dyad, and we found that a lot of the men endorsed concerns about not lasting long enough, about having premature ejaculation. And when we compared their responses to their female partner, it was surprising how often the female partner did not perceive a problem. The man perceived that he was ejaculating too soon or before he wanted or even prematurely. 50% of the time or more, the partner had no such concern. The partner was not at all worried about it. And it gets back to this notion of expectation and how often what I've heard, and this is from my clinical experience to some extent, a lot of the time female partners of men who are self-reported premature ejaculators are not so much bothered by the latency, they're bothered by the fact that their male partner is so fixated on it. The man spends so much time, I need to last longer, and it winds up frustrating the partner. That's what bothers her in many cases.
Yeah, just I guess keep the conversation going on that, and so do partners come in for men with premature ejaculation? Actually, you're right. I don't necessarily see them with the partner, and in this notion about the men's distress, right? And so when you think about what happens then, think about actually let's expand it outside of the bedroom. How does this impact kind of relationships outside the bedroom? And so if a man's really nervous about what's happening inside the bedroom, right, with whoever their partner is, oftentimes men will then outside the bedroom pull away from those quote unquote non-sexual intimate moments, whether it's holding hands, whether it's sitting together with your partner on the couch, whether it's kissing and hugging goodbye, because men will say, right, those things generally lead to something in the bedroom, and if I'm nervous about what's happening in the bedroom, I'm just going to pull away from those things. And so, it's those types of things that really resonate then with the partner. So if it's a heterosexual relationship, the female partner is saying, he's ignoring me, right? He's withdrawn, he's ignoring me, I can't communicate with him. And so these concepts that, Ellen's talking about, which is, the man's really upset and nervous, the partner doesn't seem to be, but those things like not only affect the sexual relationship, but men oftentimes take those outside the sexual relationship in the broader relationship context. And so I have to say from working with a heterosexual couple, it's those things outside the bedroom that the female partner tends to be most distressed about. That's what brings the female partner in. It's like, I've just about had enough of him, right? And so
it's funny. I also can't remember, but there was one patient I remember, and he lasted, I think it was like 15 minutes, and he was telling me, and I said, look, that's completely normal. And he said, can you tell my wife? And he got on the phone, and he called her, and I was like, look, this is completely normal. And, I don't think doing any treatment's going to make a very huge difference in this case. And she was like, okay. And but I do remember that. But that was the only one. Otherwise, you're right. I have not ever had, and I think part of it is, right, and you're going to touch on this, but like communication is so difficult about this. Men are not taught to communicate. No one's taught to communicate about sex, but even more so when they're feeling emasculated to some degree, right? Because they feel like they're not doing their part in sexually fulfilling whatever they need to for their partner. They don't want to talk about it. They don't want to bring it up to their partner and say, I'm struggling and I'm doing this. So it makes sense they wouldn't bring their partner with them when they're talking about something like this. It's already probably hard enough for them to come in to see us. And then on top of it, like, oh, I don't want to bring my partner with me.
So you had the experience, and I guess this exists too, and it's worth acknowledging. There are female partners who want sex to last longer.
Yeah.
Obviously, we're not saying nothing we're saying is universal to all human beings. Mm-hmm. And certainly this is, again, the issue of compatibility. What is a couple both bringing to the table in terms of expectations and what actually happens, and how do you synchronize those? Like Chris's example of the man who did fine with many partners, a minute and a half was fine, but now he's with someone new who wants something different, and that's a challenge for all of sex and medicine, I think, getting people to mesh their desires in a way that works.
Maybe I'll just put in a plug, if that's all right. Putting a plug for the psychological relationship support outside of the biological treatment piece of it, right? So the biopsychosocial perspective, right? So like this is a great example where if you can have those patients, like that couple, if they were just even willing to go to a session together mm-hmm. with a psychologist, with a sex therapist, with some mental health professional, just to facilitate some communication just around that one issue, right? And so if it's just something like that, like, one session or two sessions might really help that couple open up the discussion and it actually might be a springboard to do that for them where they just couldn't get by that kind of in their normal kind of regular life. And so, there are some things that maybe 1 or 2 sessions might really be helpful with. If we're really talking about premature ejaculation and we're really talking about how do we help quote unquote men last longer, like those sessions, it might take more consistent sessions, but opening up some communication, right? 1 or 2 sessions, maybe that's really helpful for a couple. And so, important to think about those concepts.
Absolutely.
Yeah, I think almost half of premature ejaculation patients have some anxiety component involved. So if you're not addressing those things, I think you're really doing the patient a disservice. And we have all seen those patients, right? Whether it's a new relationship, they're just, excited about being with this person for the first time, or just nervous about being sexually active with someone. Maybe it's been a long time. And it's always a massive component for most of these people. And in addition to it's happened once, is it going to happen again? Is this a one-off? Same thing with erectile dysfunction, which obviously is a major component for premature ejaculation, right? We always have to make sure that we're treating erectile dysfunction because, oftentimes these guys, they're really worried they're going to lose their erection before they orgasm. So what do? They rush to the finish line. And addressing their erectile dysfunction really goes a long way as well. So absolutely, I really think, we all have great resources available, and, talking about these things is so important.
Absolutely. We talk a lot on this show about the physical side of health, but mental health is just as important. As many of you know, I've been going through my own health challenges with breast cancer and my husband having colorectal cancer at the same time. And it really takes a toll on your mental health. That's why I wanted to tell you about Rula, because if you're struggling, you deserve access to affordable mental health services. Rula is a healthcare company that makes it simple to find a licensed therapist or psychiatrist who's in network with your insurance. They partner with over 100 insurance plans, and the average copay is just $15 a session. With mental health, I think it's so important to find the right fit. And with Rula's network of over 15,000 therapists and psychiatrists across the country, you can find one that fits what you need, that matches your specific goals, your background, and what you're going through. And appointments are available as soon as tomorrow. Rula sticks with you throughout your journey, checking in to make sure your care is helping you move forward. Thousands of people are already using Rula to get affordable, high-quality therapy that's actually covered by insurance. Visit rula.com/Rena to get started. That's RULA.com/Rena. You deserve mental health care that works with you, not against your budget. So let's talk about what's happening physiologically. Why do some men really have premature ejaculation? What are the causes in terms of biology?
It's not well understood. Yeah. Ultimately, we know that there are certain studies suggesting a familial component. Not most men don't talk to their dads very much or their brothers about premature ejaculation. It doesn't come up in conversation too often. But what data exists on it does suggest there could be some familial component that's supported by data suggesting, and these are relatively minor effects, each one of there's no premature ejaculation gene per se, but there are what are called allelic small nucleotide polymorphisms, little segments of genes that vary between men and people. And those have been associated in a few studies with alterations in serotonin metabolism. Serotonin, the neurotransmitter, also dopamine, a neurotransmitter, both of which are intimately involved with sexual responses and sexual activity. And these data suggest that incremental small changes in those alleles and how the brain processes serotonin can influence ejaculation latency. Now, these are hard studies to do. It's a lot of variables. And the effect of any one single difference is minor. So there's a notion, there's something about a set point, a thermostat, if you will, of what it takes to push a man into orgasm, and that's probably to some extent determined biologically. Context matters, how aroused a man is, who he's with, how old he is, how he's healthy in other ways, what his penis is doing. Those play into it as well. And those are things that are sort of intrinsic. And historically, there's been a lot of interest in, is there a problem with, prostatitis, a term that gets thrown around a lot? Is there a problem with thyroid hormone levels? Because there's some evidence to support that hyperthyroidism, too much thyroid hormone, is associated with that as well. Does testosterone influence? Possibly. There's some data suggesting that testosterone levels play into that and higher testosterone associated with shorter latency. But again, this is a very complicated topic. And it would be nice to boil it down to, oh, there's a gene, oh, there's a testosterone level, oh, there's a urine test. You do that and your premature ejaculation goes away. It's not that simple. Nothing in sex is that simple. And these are things that are conversations we have, and we try to elucidate which of these are potentially salient and which of these can we modify. We can't do gene therapy for this, obviously. So we have to just sort out what do we think is contributory. And to some extent, a lot of it, I'll let you speak to maybe the psychological aspects of it, but I think that's a big part of it too.
Yeah, and I think, so the biological parts, of course, I'll let you take for sure. The psychological parts, yeah, I think it's just, it's potentially around these expectations and anxiety and what men are thinking as they're approaching kind of that sexual situation. And certainly there can be an anxiety loop if a man has a situation where he's not performing as well as he wants to in a sexual situation, right? So that's going to happen to every man multiple times in their lifetime, right? Mm-hmm. So, what kind of anxiety does that lead up to the next situation, right? And so with premature ejaculation, there can be this anxiety cycle where, men becomes hypersensitive then on, like, am I lasting long enough? Am I going to ejaculate? And that creates anxiety, which then actually can lose a bit of control, which might cause him to ejaculate more quickly. And you get into that anxiety kind of ejaculation cycle. So can be a piece of it for sure.
Yeah, and I think there's also this hypersensitivity theory, right, with the nerves of your penis, which is also a component for some of the treatments. And the reason why we bring all these things up, because these are exactly how we treat people with certain medications, certain ointments, some creams, some therapy. People are complex, and I know that it either goes up, it goes down, it comes out, but it's more than that. There's a lot going on, and it's truly a biopsychosocial aspect of sexual health, and there's so many layers to it. So I think it's important that you go see someone to get assessed, because we can't just put our finger on one thing oftentimes and say this is the thing that's going to fix you.
Yeah, and I don't think it's the same for everyone. So I think you'll see like these online courses or things like, you're going to last longer if you do X, Y, Z. And I think the thing is, like, it may work, but if it doesn't, then it creates even more anxiety, right? And so I think talking to somebody about things and realizing that it's complex and there's a lot of factors and you may have to pull multiple different levers to really get there. I think also there's some potential evolutionary theory, right? Where, because if you look at other mammals, they ejaculate very quickly because evolutionarily you want to ejaculate quickly before there's other pressures, other people coming in. You want to make sure the semen gets where it needs to go. And so there may be potentially an evolutionary component where these people are actually evolutionarily would have been, better or more fitter in terms of being able to spread their seed. I'm just curious if you guys have any thoughts on that.
I mean, it's evolutionary psychology. You can't really prove it one way or the other.
Right.
It's always an experiment that can't be run. And it's a nice theory to say, just get it in there, reproduce the species, and then we're done. And animals, as you say, do that. Some animals do actually have prolonged intercourse. It does happen in the animal kingdom. But more often than not, it's quick. A theory that's advanced to say, well, why does it, you can argue, it's good to get it in there quickly, ejaculate, procreate. You could argue that there's a bonding element, humans being such social creatures, needing to have a social network. An individual human's kind of useless. Many humans together are unstoppable almost. And the notion is that part of the nucleus that holds people together is that intimacy, that bonding, that oxytocin we get from sexual relationships, the nuclear family being the core. Obviously, there's many different kinds of nuclear family, in my opinion, but a bonded pair of people and their children together, and that connection between the parents of that is, in large part, and again, conversations I've had with my spouse, that bonding of a couple together is mediated in many ways. A lot of it is sexual. Oxytocin released to kind of make you able to tolerate living with somebody. Bonding together and feeling close in that way is very essential. So I think there's an argument to be made that making that experience richer, longer, more pleasurable, and I'm not saying that it has to be a certain amount of time, but making it an intimate experience that bonds people is also evolutionarily sensible to make units of families and communities hold together.
Yeah. I think it's interesting. I think just knowing that this is nothing you've done wrong, right? And potentially there's factors that are biological in addition to psychological is helpful for a lot of people. And just knowing that, I think it's actually interesting. You had shared like sometimes the partner isn't bothered. So I distinctly remember having this conversation with my friend. She's like, I watched your video where you said average time to sex is about 5 minutes. And she's like, it actually made it easier for me to have sex with my partner because I knew it wasn't going to take that long. And like, I wasn't going to like disrupt like whatever I needed to do or going to sleep. And I was like, that's funny to me, but it was like helpful because she's like, yeah, I enjoy it obviously. But like sometimes like, oh, I've got so many things to do. And she's like, now I know it doesn't really last that long. So you're right. It doesn't really last that long. And I was like, it's so funny.
You can fit it into your schedule.
But you don't really know, right, what the other person is thinking because, unless you actually ask them. So which brings me to like communication. I think, this is the hardest thing for people to do. So what are some ways that you help couples communicate with each other about these struggles?
Yeah, well, and I think, so if the couple actually comes to me, if to the point where they come to me, I'm in it, right? It's a good situation, right? Because they've come, they're asking for help, and they're looking for that help, and then it's just facilitating the conversation, kind of, in the session. I think the more difficult piece, right, is probably kind of, for all of you in your urologist offices, like, what do you do with a man who's really reluctant to potentially bring in a partner or even talk about it with the partner? And so, oftentimes I suggest using kind of the appointment with whatever doctor they're seeing about this, using that appointment as a jump off place where they can start the conversation with their partner. So men are going to be anxious about it, but they might say, oh, I saw a urologist today, when they're with their partner and talking, or many times the partner's making the appointments and scheduling the appointments, and the partner follows up and says, what about that appointment? And encouraging the men to be able to actually bring it up and have some initial conversations with their partner. It's kind of that first step. And then hopefully what that leads is to a few more steps along the way. But really I think from a urologist perspective, how do you encourage, encouraging them to bring in their partner and have that discussion? So, Justin, like those patients were bringing their partners, right? You then can have that conversation.
Because it's already being had.
It's already being had, right? And so, but then once you bring your partner in next time, and we'll be able to talk as a group, facilitate that conversation, then hopefully, again, that's another jump-off point to say, listen, if you're interested in potentially talking about this more or need some more assistance, one is you can certainly talk with it on your own. Like these are opportunities. But the other is that, I work with a psychologist who's really good at working with couples, and, maybe just a session or two, and start with a session or two. You don't have to say this is going to be forever, or it's going to be a year, or it's going to be weekly for 6 months. A session or two might really help, kind of you as a couple be able to communicate and talk about it.
Yeah, I think for me, like, and I think Alan will agree here, it takes at least 2 to 3 visits oftentimes to really convince a man to go to seek a therapist or a psychologist. And oftentimes what I do, there's 3 referrals that I struggle to get right off the bat. 1, checking for sleep apnea. No one thinks they have sleep apnea, to get the sleep study. 2, see a pelvic floor physical therapist. And 3 is to see a therapist. And oftentimes that first visit is explaining, hey, this is a potential component of this. We'll check everything else to make sure that everything else is normal. And then on that second visit, listen, everything else is normal. We tried X, Y, Z. I think it's time for you to finally go see a therapist. And oftentimes, like, a little bit of reassurance, a little bit of hand guidance is often the thing that's going to get them there. But it is a struggle because a lot of times it's not that first visit. Unless it's a very specific conversation that they can point in the one thing that they know. I'm going through a divorce. I have a new partner that I'm very anxious about. Other than that, it's often very difficult to get them to see you guys right away.
I think you're spot on. And it's across all male sexual concerns. Yes. Men are resistant, like, no, this is nothing psychological about this whatsoever, which is patently ridiculous in my opinion. I know why they're saying it. I get it. I understand it. I empathize with it. At the same time, Chris's biopsychosocial model is what I invoke to them, is that sex is way too complicated to be purely biology, to be purely psychology. And I try to sometimes couch it in terms of the biology, however, to say, like, look, anxiety is a natural response, depression, all these other mood things. When you're in that state of being, your body has one stereotyped way to respond. It's with autonomic nervous system activation, sympathetic nervous system stuff. And the sympathetic nervous system, fight and flight, your body's stressed, it's reacting the way it must and has to, and this is all humans have this, myself, you, the patient, anyone. That response is generally anti-sex. It is not facilitating sexual responses, and therefore, I'm not saying it's in your head or you're making anything up. I'm saying that the way your body reacts naturally to stress like this is not going to help you. And I think working that out and talking to an expert like Dr. Nelson or many great experts out there is going to be part of the overall treatment package. Not the whole thing, not the whole story, but a big part of it.
Well, I think most guys, when you empathize with them and say, look, I know this is devastating for you. This is really hard and I can help you as best I can. But like, I think talking to someone about what you're struggling with is helpful. It doesn't have to be with a partner if you're not ready to do that. I think even just like acknowledging like, yeah, this is horrible and you're probably thinking about it all the time and it's probably really stressing out your relationship and it's probably making it hard to meet a person or whatever. And I get that. And I want to be here for you, but I'm not a psychologist, right? And like, maybe talking to someone would be helpful. And I think that does go a long way because the psychological toll is pretty immense.
Yeah, absolutely. And I think even if you had the perfect treatment for them, right? And so whether it's premature ejaculation, whether it's ED, like, okay, I've got the perfect treatment for you, right? There's still so much that happens within a sexual experience. And then the history of them being nervous and anxious potentially about this concern, whether it's a real concern, whether it's kind of made up or not. The nervousness, the anxiety then has already had an impact on their relationship. And so like to really think like, I'm going to give you this pill, everything's going to be fine, when the past 2 years, right, things haven't been great because I've been so nervous and anxious or that we haven't been able to talk about it. It's just, we know that these treatments work, right? They're more effective when kind of it's a multidisciplinary team that's really working with the patient and helping the patient.
What are some behavioral things you think people are doing that is particularly in acquired premature ejaculation that may be contributing to some of that?
I think this is hard, right? I mean, I don't know if there's really much data supporting any of this stuff, but I think we just are in a society where people now in the manosphere, I think, are telling people that they, need to be lasting longer, be more of a man, perform a certain way, act a certain way. You hear on the media, you hear on social media as well, dating's bad, being in a relationship's bad, everything's bad. And I think when you finally have the opportunity to be with someone, you're like, this is cool. Maybe all that pressure can build up. So I think, there's a lot of societal things, but it's always been that way, right? It just has presented itself in new and different ways. And unfortunately, I think, we have just more access to those pressures. And, the truth is men lie. We all lie to our friends. We lie to our buddies. We're sitting in around having a beer, watching football. And I rocked this girl's world for 2 hours last night. In my head, I'm like, no, you didn't. But, but people don't know, right? So, it is this game that people play amongst their friends. But there's also this bigger pressure amongst society from men to other men. And I think it's even more pressure than I think women put on men most of the time.
It's that performance thing
Yes.
we were talking about earlier. And I will say that, I'll echo again my spouse, and we both have the same commitment that the things that contribute to general health, regular exercise, healthy diet, stress management, avoiding tobacco, we know that these things are very, very strongly linked to risk of erectile dysfunction. I will say that in some cases, my ideas are, not my ideas, other people's ideas, are that acquired premature ejaculation can in some cases be comorbid with erectile dysfunction. And a man who's so-so on his erections, worried he might lose it, might want to speed up, he might change the way he feels during sex because his erection is less reliable, and that is one potential contributing factor to some cases of acquired PE. So again, if we were talking about advice to give, advice that's never wrong would be, attention to healthy lifestyle behaviors. And obviously the corollary to that also a healthy relationship. I think we're probably setting ourselves behind if you're not fostering your relationship in a way that makes you feel good about your partner outside of the bedroom. And that's also going to be contributory to a lot of these problems.
Yeah. I mean, I think we've sort of alluded to this, but I do think in terms of relationships, sex is like the ultimate form of intimacy for a lot of men. That's what intimacy is. They don't think of intimacy as the other things necessarily. And so when there's a problem with that, it can create such a discord in the relationship because they're like, well, now I'm not intimate with my partner. right?
Well, and then if I just
Yeah.
now I'm not a man, right? I'm like, I'm not pleasing my partner. I'm not a man. I'm not the person I should be, right? Can go to the core of what it is, really, to quote unquote be a man, right? And the perceptions of what that means. So absolutely can have an impact.
Yeah. And I think to your point, the one thing I do think behaviorally, stress is such a big part of it. We live in sort of a time where we are constantly bombarded by stressful information, right? Before it was the news when we were growing up. Now it's your phone. There's constantly something that's going to pop up that's going to stress you out. And people are not coping with these things ever, right? They're just like consuming all this stressful information. They're constantly working. They're checking their emails. They're like, there's just not a lot of wind down time to reduce stress, and then they're expected to just have sex, right? Like, oh, if the opportunity presents itself, I better have sex. And you haven't even allowed yourself to calm down and enjoy and like turn on the parasympathetic nervous system to actually be able to enjoy sex and actually luxuriate in it. And so you're still operating under that stress, and I think that plays a huge role.
Mm-hmm.
You're kind of rushing into premature ejaculation.
Right. Yeah.
Well, it goes to the stereotype, right? The man's always ready, right? It was always on, right? Just as if you were 18, 17 or 18, right? You're ready to go. It doesn't matter what's happening in the environment. Doesn't matter what's happening around you. Doesn't matter what's happening with you internally, the relationship. You're ready to go, right?
Mm-hmm.
You're a man.
That's sort of the pressure men put on themselves. They're taught to.
That's really sad. Someone said recently, like, just because you have an erection doesn't mean you're turned on, right? And I think that's so important because I think, one, it's like women are like, oh, you should be ready when I'm ready. And, oh, you have an erection, you're absolutely ready to have sex right now. And you may be, but you may not be. You may need to still have the intimacy before the foreplay. Like, it's still an important part of the relationship. So in terms of like treating premature ejaculation, there are like behavioral techniques that we try to teach patients, like the start-stop technique, the squeeze technique. Let's talk about those a little bit. How often do you find them to be successful? And, what are the challenges in sort of starting to do those?
Yeah. So, I'll jump in a little bit here, right? And I'd love to hear kind of your guys' opinion on this too. And so I think they can be effective. I think the idea is that this is where you probably need more consistent treatment with someone who's, again, whether a psychologist or a sex therapist, someone who really understands these techniques, right? The baseline of these techniques is you're trying to help the patient become more in tune with what's happening with their body, right? And so when is that sensation? When is that point where there's no return, right? And how do I continue to bring myself close and understand when I'm close to that point, and then can I just then bring myself, down from that point before I ejaculate? And so, I think there's a chance that they can be effective. I think part of it is consistency, right? It's going to need some consistency. It's an approach, and as you're working with a professional who really understands the techniques, oftentimes that consistency is not there, and so it's really like in terms of the data, right? What's the data on this? It's really hard to tell, right? Because we just don't have that type of consistency related to it. But I think a number of my colleagues have found them successful if, in fact, there's consistency.
Well, and they have to have buy-in from the partner, right? Which I think is the challenge.
No, I think the consistency is always the problem. I think guys, we want to fix that we don't have to work towards, unfortunately. And that's the truth, right? Give me a medicine, give me something else. I just want to get this better. Right. And I think that's where it does become. And it's also can be uncomfortable with the partner. A lot of the times, you tell them to do it during masturbation, obviously, first, to really train themselves to understand where they can start and stop during penetrative sex. But I do think it is very difficult to get guys to buy into that.
Yeah. I think. Sorry, just going quick. I think that what else is hopefully also happening in these discussions are discussions about the man's anxiety, right? About kind of what's happening with his self-esteem, discussions with the couples around communication. So hopefully it's not just like, oh, what's happening physiologically with you kind of in the stop and start method, but the other components that can be helpful in this are integrated into that approach, right? Maximizing, hopefully, kind of the effectiveness of it.
Yeah, the start-stop technique was pioneered by, once again, Masters and Johnson, and they've reported very high success rates in their super specialized, very intensive 1950s and 60s clinic, where people were demographically different, probably socio-culturally different in that era, and no one ever really replicated those results. But I think what Chris is getting at is that on the physical side, all these techniques are centered around getting to know your body's premonitory sensations. And there's a point of what some people have called ejaculatory inevitability, where it's going to happen. Nothing you can do to stop it because it's a reflex. But there's like a point, a threshold where you're not quite there yet, where the man still, again, assuming he doesn't have premature ejaculation or he hasn't learned how to control it yet, he can sense that and say, okay, now it's time to back down a little bit or change things up, or the old joke about thinking about baseball or grandma, to kind of, obviously that's taking yourself out of the experience. That's kind of a counterproductive way to approach it by trying to distract yourself from what you're doing. I'd say that's generally not pro-sexual to do that. You want to find a way to stay engaged, but also exercise control if that's your goal, if that's what you both want as a couple. So I think those are the really important things to think about when you're approaching that. Now, the other side of it, like the partner buy-in, is something that's also important. So the partner integrating touch, integrating awareness of the body, sometimes even physical therapy. Before I forget to mention it, pelvic floor physical therapy has been touted as once again, a way to get familiar with pelvic sensations that are sort of clues that, oh, I'm getting close here. Maybe I need to be more aware of this and pay attention to it and use that to guide my experience. When I was in training, I just want to throw this out there as well, partner participation, the notion, what does the partner do while the man is doing these behavioral techniques? And the thing that they talked about when I was in training 20-some odd years ago was the idea of the quiet vagina. And it's a rather odd term. And it's a term that basically meant in these heterosexual couples, the female partner was expected to lie completely stock still, moving not at all, so that the man could exercise control and wouldn't be overly stimulated would his partner happen to move. And obviously, even at the time, I thought, well, that's a weirdly misogynistic idea that this woman is this passive receptacle with her quiet vagina. And I told a friend of mine, not my wife, another friend of mine with whom I'm very close and can share details like this with. And she was like, well, what if I want to have a noisy, loud vagina? And I was like, well, yeah, you should be able to do that if that's what you like to do. And the notion of, getting the partner not just to be a passive observer or receptacle of sorts in these interactions when a man is training himself up, but an active participant, active in a way that's going to help him last longer if that is the couple's goals, but not as someone who is passively just helping this man achieve some goal that's his own, not so much hers.
So the other piece about hopefully what's happening kind of in these discussions is expanding the sexual repertoire, right? And so the concept for men, it's penetration, right? That's what sex is. Let's expand that repertoire with the couple so that the sexual experience is much more than penetration, right? And so where is that noisy, fun, loud vagina? Like maybe that's in penetration, maybe that's not in penetration, maybe that's in manual stimulation, oral stimulation, maybe that's with toys. Like how do you expand it and really kind of helping men understand that they actually can be better, quote unquote, in bed. They can be a better lover, right? If they expand their sexual repertoire. It can be kind of much more enjoyable for the couple and potentially the partner if there's other things to incorporate other than this kind of really strict notion that it's it's erection, penetration, orgasm done, right?
Yeah.
It's not just your penis.
And stimulation of the partner doesn't have to stop just because you've ejaculated,
Yes,
right? I mean,
1000%.
there's many other ways to stimulate your partner, and there's tools, there's so many oral sex, there's so many options. So like it can still be a wonderful experience, right? So I absolutely agree.
And just on that point, just understanding though that this can be a bit of a paradigm shift for men. Mm-hmm. And so for us to kind of sit around and say, but you can be better in bed. There's other things to do in bed. Like it's not just about penetration. It's not just about that erection. It's not just about your orgasm, right? To talk with men about it, it's not necessarily something that it might not happen overnight, right? It's a paradigm shift in how to think about the sexual experience. And we need to kind of help men think about that and actually help the couple think about how to shift that paradigm and what that means. And so it's absolutely kind of the goal that hopefully all couples are trying to attain, but also know that it can be difficult to get there. And it's not just about like, oh, you should do this.
Absolutely.
And then
Absolutely.
I think they're going to go do it.
It's a shift for both partners because I think it's also ingrained in society that this is what sex looks like and this is what it is, like penetration, orgasm, done.
Of course, for your friend who wants 5 minutes, maybe, that's why it's important to talk as a couple. What does the other person want? When do they want it? Like when can we do something that's 5 minutes? Because I've got a busy day tomorrow, and so we can get something in the night.
Yeah, you don't want to hear, let's wrap this thing up.
Come on, let's go.
It's not part of the plan here.
Yeah. But she's satisfied. That's all that matters.
That's right. Absolutely. Right.
There's some data on things like yoga, high intensity interval training, running as a way to like sort of tune into your body, and that translating to longer time to ejaculation. It's very small data. Have you guys had any experience with that?
Personally, no, but it makes sense to me, right? We've already spoken about how our overall health, eating healthy, exercising can impact our sexual health for sure. So, people who are finding new modalities to get the fitness level that they need, I think it really makes sense that it's going to help them in the bedroom for sure.
There's never a negative about it, in my opinion. Right. And I think that the general life benefits will spill over to sexuality when someone is engaging in healthy lifestyle behaviors.
And you'll look better. You're probably more confident in yourself.
100%.
And, that is a huge aspect of it as well.
And since we've been talking about confidence, I want to take a minute to acknowledge how much things like the way we look and changes in our hair and skin can affect how we feel in our bodies. I'm not immune either. Even I've been struggling seeing my hair get thinner every year, and I got the iRestore Elite to help me. The iRestore Elite is a red light helmet with 300 lasers and 200 LEDs to deliver low-level light therapy to keep your hair in growth phase longer, increase blood flow, and reduce inflammation. And it's so easy to use. You wear it for 12 minutes every single day, and it's super comfortable. I just do it while I'm winding down reading before bed. It works by stimulating your hair follicles at a cellular level. People start seeing thicker, fuller hair in as little as 3 months. iRestore has been in the space for over 20 years, and they back everything with a 12-month money-back guarantee. The good news is iRestore is offering some huge discounts on their red light therapy devices. Right now, you can save on customer favorites like the iRestore Elite Helmet and the Illumina Face Mask. Just head to iRestore.com and use code RENA. That's Rena, RENA, at iRestore.com. Please support our show and tell them we sent you. Give your hair and skin the upgrade they deserve so you can feel confident and refreshed.
And those things tend to reduce anxiety, right?
Yeah.
They tend to, so if you're really anxious, your baseline anxiety is like a 4 or 5 out of 10. Those things might reduce it to like a 2, which then helps you, right? Kind of the notion of like your reserve, right? Your anxiety reserve or your mental health reserve. It helps you be less anxious in other situations, and
Yoga is wonderful.
Certainly is good.
I love
right.
yoga.
Yeah.
Like Shavasana, is the only time I'm like completely blank in my brain. It's awesome.
Yeah. Exactly.
What about, you did mention pelvic floor physical therapy, and I think people hear that and like, oh, I should do Kegels. Is Kegels the answer? You're already shaking your head no. So
Well, it's funny. I mean, pelvic floor physical therapy is fantastic. And I think reducing the pelvic floor physical therapy to Kegels is a disservice to our pelvic floor physical therapy colleagues and to what the field is in general. I think Kegels, again, my opinion primarily, is that Kegels are excellent for stress urinary incontinence in persons of any gender. And I think for that, it's fantastic. I think Kegels are actually counterproductive in many cases, especially when you think about people with high-tone pelvic floor, chronic pelvic pain patients. They don't need more tension. Kegels create tension and create strength, and that's good if you're incontinent. Not so good if you're already tense and in pain. So I don't think that, again, I would defer to my colleagues, and I would say it probably needs to be individualized. A man should not just start doing 1,000 Kegels a day in the hopes that he's going to last longer in bed. If he really wants to get a good, nuanced impression, he should see a physical therapist with expertise, get an evaluation of his pelvic floor to see what's going on down there. And it could be anything from maybe Kegels help, or more likely, maybe relaxation is going to be what you need. You need to relax that pelvic floor and make it less tense, and that might be what you need to do.
Yeah, I mean, for my patients, how I explain it to them is, a while back I used to play football. I tore my ACL and I needed PT after my ACL repair. And the PT wasn't just one exercise. They had to do an assessment on my knee, and they gave me multiple exercises, different things that I needed to do to achieve the goals that I wanted to. And the same thing is with pelvic floor PT, right? They are a physical therapist, and they have multiple things that they need to do to make sure that your pelvic floor is working that it needs to be. So when we break it down and think about just Kegels as one thing for this whole specialty, it's really not fair. And I think that we really need to understand that these are physical therapists, just like you have a knee problem, you're going to a physical therapist, you have a back problem, so there is a full assessment. And that's why I try to explain to my patients where they go, I'll just go home, I'll do Kegels. I'm like, that's not the solution here.
Well, and I see that like a lot of these guys are very anxious. And so oftentimes we see people who are like type A personalities, high anxiety, they actually have a high tone pelvic floor. And so doing Kegels will make it worse, right? And so if you don't know and you don't understand, like it may hurt you, it may make things worse. It may cause pelvic pain. It may cause urgency and frequency and constipation and other issues if you are just trying to figure it out yourself sometimes.
Yeah. Our physical therapy colleagues are really happy with the discussion right now.
Yeah.
Because they hear Kegels, they're like, no, not Kegels.
And look, for some people that might be the right thing. But again, it's not a panacea. What about tools that you can purchase online to help you last longer? Like there's stamina trainers, wearables, different things that are coming on the market. Any experience with those? Thoughts on those?
I have no idea. I'll be honest with you. I'm not really sure. I don't think there's really any data on them. I mean, we have things that I'd probably recommend you try that we have data to support, but I don't know. What about you guys?
Well, there's different theories on it. And the notion of, can you train yourself up? Can you overcome your biology? Can you use this as an adjunct, much as like you would use a crutch if you break your leg, if you use a splint, if you break your arm? And I don't think anyone who tells you use this device and you will last an hour in bed, it's funny. I'm on some social media and it's funny to see the ads like, you need to masturbate more. No, you need to masturbate less. And you're getting conflicting information about what's going to cure you of your problem, in this case, premature ejaculation. I think that used properly, you could think that, a way to condition oneself is to become, once again, ideally under the guidance of a therapist or someone with expertise, or a physical therapist even, finding ways to use devices to train and to get familiar with your own body and those premonitory sensations that lead up to ejaculatory inevitability. I certainly think devices such as these maybe would help. It would have to be done with an understanding that it's sort of a proxy, a thing you're using to train, and I would not count on it being effective simply because there aren't many data. There's some data. Actually, if you look at some studies out of Japan and some other places, they've done studies on these masturbation sleeves, et cetera, reporting good results, but they're small studies, not placebo. You couldn't really do a placebo control for a study of this nature. So I'm certainly not opposed to it. Again, I would not want people doing anything invasive, inserting things in their penis or taking an unknown medication or anything that puts a lot of pressure or leads to pain, because that's too much. Something is not right when it's that way. But I don't have an objection in concept to any of these things. But as Justin says, the data aren't strong, so I can't really give a strong recommendation on them.
Yeah. It just depends on the cost too, right? And so, it becomes a cost-benefit analysis. If you're not really sure on the data, but it costs a lot, maybe that's not something I would recommend. If it's low cost and relatively easy to get, accessible, maybe it's something that they can try.
It's just weird because there are, like, I've reviewed a couple papers like of these devices out in Europe. They put it on your perineum and it seems to like overstimulate it. The data's impressive, but that was like 6 years ago. If it's so good, where is this stuff, right? And you have to always ask yourself if for any product that someone's selling you online is, if you hear this is what doctors don't want you to know about, or if you hear like this is going to solve all your problems, why wouldn't everyone know about it already? Yes. It's just one of those things. You have to use common sense. It's hard, especially in the men's health space where everyone wants to be private. But if someone's telling you like this is going to solve all your problems, we would have explored this already as physicians. So we would be recommending it.
Yeah, we want to help you.
I'm happy to be, curing everyone's erectile dysfunction or premature ejaculation. That's not going to put me out of business. Don't worry about it.
Yeah, we've got enough to do.
Exactly.
But if you're only hearing about it at 2 a.m. on some infomercial,
exactly.
I mean, if it was that good, they'd be advertising at 7 p.m. prime time across the billboards around the world, and everyone would be buying
Everybody
it.
would have it, right? It would be like, I don't care how much it is if it works, right? And they would be billionaires.
I think I think the other thing too, just about the data around kind of anything in sexual medicine, right, is the placebo effect can be so strong in sexual medicine, and so you have like a single arm study, right, and with no control group or comparison group, and well, we probably see, and I think we've seen the data, right, somewhere between 20 to 30, 35% kind of response rate, which is a placebo effect in sexual medicine. And so a single arm study, it's not a surprise almost just with anything, actually, that you might get some results. Yeah. It's important to think about that, and important to kind of, help patients understand that too.
Absolutely. On that topic, are there supplements that can help men with premature ejaculation?
There's none that I would say I would recommend. I would say that my biggest issue with supplements, number one, they're not regulated. So there was no one overseeing the manufacture, the purity, the concentration, how it was handled, what's even in there. And there's plenty of data to suggest, at least in the erectile dysfunction space, that a lot of all-natural ED supplements actually have sildenafil, also known as Viagra, or similar drugs in them. So they're not all natural, they're pharmaceuticals, and they have some risks. So there's a lot of issues with purity and how it's processed. There's not much data. It's hard to do a good study of that. There's no randomized controlled studies of any kind of supplement for premature ejaculation. So my advice is always, caveat emptor, buyer beware. Ultimately, maybe this works. It might. I can't say it doesn't. I also can't say that it does. And my bigger concern, again, is that I don't know what you're buying. So use your own judgment. If it works for you, maybe it's a placebo. Maybe it doesn't matter if it's a placebo. Maybe if it works, that's okay. But I just want people to be very cautious because there could be risk. This is not, because it's, quote, all natural doesn't mean it's safe.
Yeah, I mean, Botox is natural.
Mm-hmm. Yeah, so is anthrax.
Right.
And arsenic, all natural.
All natural. But yeah, I agree. I say the same things. And I think, we don't have the data, and we never will, because people will buy supplements without data. And so we will never have the data. And so people can say they've ran a study for 3 months. That's still not sufficient. We would never have a pharmaceutical with 3-month data. And so we're never going to have the long-term data. And so buyer beware. Absolutely. In terms of doing things like cognitive behavioral therapy or other techniques to help people or even couples with struggling with premature ejaculation, what is that? I think for people, they don't really know what to expect.
Yeah, sure. And so cognitive behavioral therapy is CBT, right? Cognitive and behavioral therapy. And the cognitive piece are really addressing cognitions, like things that we think, right? And oftentimes you're addressing the negative cognitions. And so when you think about men in this situation, they think, I'm not a man. Like I'm just not good enough. I'm not a man. I can't please my partner if I'm coming too soon. And so part of working with a psychologist or a sex therapist might encompass those cognitive, quote unquote, distortions, right? Or how do you address those? So that's number one. That's the cognitive piece. The behavioral piece are just some of the things that we've been talking about in this situation, which are, the stop-start method, the squeeze techniques, those types of things. They're behavioral approaches where a patient's doing something, they're trying to become, in this case, right, more sensitive and more in tune with their body sensations during a sexual experience. And so that's the CBT. Other types of, quote unquote, the B part, the behavioral part, that may be helpful are things like the mindfulness approach. And so Lori Brado in Canada is doing a lot of work on mindfulness within the sphere of erectile dysfunction. But you can imagine that those techniques, which is being kind of self-aware, right, being aware of the moment, fit really well with this notion of how to be more aware of what's happening with your body and more in tune with those sensations. And so it's those types of things that are the CBT that would be applied here. I think, Justin mentioned, like, you try these techniques, you potentially have them practice in masturbation first, trying these techniques. And really, when you think about performance anxiety, what's one way to address performance anxiety? It's to practice, right? And we're at AUA, and if we give presentations, you're nervous about it, right? And so what do? You practice beforehand. The more you practice, the more comfortable you become. And so the notion of trying or practicing these within masturbation, when you're on your own, right? There's not kind of, am I pleasing my partner or not, that can at least help, hopefully reduce some of the anxiety and apply them then with your partner.
Yeah. That's helpful. Do you see modern technology like virtual reality or other things changing the way people can either access therapy or do therapy?
Well, I mean, so certainly modern technology in terms of apps, in terms of AI, right? If you look at what's happening kind of in the mental health sphere and the experiments with AI, we're getting pretty close with AI. There's going to be AI therapists for sure. Yeah, and so from that piece, yes, there's no doubt about it. Well, generally, what happens with those type of apps are AI, those types of things. What you can do, what's the benefit is you can get to people broadly, right? Especially on sexual medicine. So men might be able to do it on an app where they don't have to be embarrassed about going to talk to someone or kind of talking with others about it, right? So, but the benefit is you can get it to a lot of people. The effects tend to be pretty small. And what's really interesting, even with AI in mental health, is that when you add a human component, that's where the effects go up. Mm-hmm. Right? We know that in terms of psychotherapy and psychotherapy research, the amount of level A, excellent randomized controlled trials in psychotherapy, there is hundreds, right? And so so much so that the NIMH, the National Institutes of Mental Health, right, has actually stopped funding psychotherapy research, just general psychotherapy research, because we know it works. But it's taking and then applying what we know kind of from that research into specific situations like this. But the effect then, when you add a human component, you should just see the effect just increase dramatically kind of over this notion of AI only or an app only. And so really interesting. The other the other techniques, and just in terms of things like treating phobias, there's really interesting techniques where you use kind of the goggles and the visual kind of the visual experiences, right? And kind of veterans coming back and actually kind of the PTSD and having them kind of the re-experiencing is what really kind of what the theory is. I'm not totally sure that would apply to premature ejaculation, but there might be some other things, those apps and AI.
Well, in theory, you could do a VR of a sexual experience, and so they would be potentially feeling like they're in a real sexual experience with the related anxieties, perhaps.
Yeah. I think that's an interesting idea, and whether it's therapy replicating a sexual experience or just going through some things with the AI and talking about it. I was speaking to my therapist about this, and she once used the analogy, some people come to therapy for a massage and some people come to get challenged, and I think therapy ultimately has to be both. And I guess a perception I have, from things I've read, there was Science magazine had an article about this, that AI tends to tell us what we want to hear. Mm-hmm. So the AI therapist is going to be great at the massage. They're going to give you this nice therapy massage, make you feel good about yourself. But a human therapist who's good is going to challenge you. They're going to tell you the hard truths in a sensitive way. They're going to come bring it across that, hey, here's your part. Here's what you're not doing right. Here's what you need to work on. So I think that's where you need to make sure that the AI gets enough of that tough love kind of element into it, where it's going to be the full package. It will never replace a real therapist like yourself, but I think ultimately it's something that is going to be a challenge in AI, that it's not just about buffing you up, it's about challenging you.
Yeah, but I also think like in sex, we want a human validity, right? We want someone else who's actually there to hear us, to show us we have value, and to demonstrate that, there's a connection there. And it's the same thing with sex. So, and even with the VR sexual, treatment, it's still not simulating reality, right? And that's the issue that all porn has, which is good and bad, right? And that's not a judgment, that's just a fact. So, what are we going to do? We're going to have someone record their actual partner pretending that, that's probably the most intense version of that. But if you're just doing it with some random person in a nice room that has nothing,
not real, yeah.
It's just, you're not simulating reality there. And I don't know how helpful that can be compared to a true human interaction in any aspect of it.
Yeah, and even kind of even though, kind of masturbation's not with that human partner, you actually have some of that, the real life, experience where you can practice, right? You can get used to these techniques, the stop start, kind of understanding where that, kind of where that no return point is. And so it's VR is used for experiences where you can't replicate, right? So with veterans, right, and PTSD, we're not going to replicate them going out on the battlefield and doing that all over again. So they use the VR experience. Whereas masturbation is a place where it can be practiced, and actually, might not need VR in this situation.
Or one of those real, well, taking the next level, if you need like a real doll integrated with AI, where it becomes like, oh boy, we're going maybe too far if we do that, because all of a sudden you have
also expensive. Let's be honest.
Really
like we have cheaper options for you
for the
treat.
for the rank and file. Obviously not some mass consumption. For
Yes.
that.
Yeah, they're expensive.
Not always a good idea
but
either.
They are,
I don't think
they are getting very advanced. So
this is just a quick comment on gay relationships. And so gay relations versus heterosexual relationships. Gay relationships tend to be more open relationships. And at least when I was in New York, right, I would say 90% of the men in gay relationships, they were open relationships. And that for gay men, this really does have a benefit. It's like a real life VR, right? Because you can then have a one night stand. You can kind of organize this. And what men do is they organize kind of this sexual experience with another man they don't know. And they can usually kind of in the communications beforehand say, listen, I'm struggling with X, Y, and Z, right? And so it gives them a chance to try some of these techniques, kind of experience it in a maybe lower anxiety situation with a partner. And to some extent, so it's kind of where gay men may have an advantage in working with things like premature ejaculation.
So why can't we bring that mentality to men who will have sex with women?
Because gay men talk about sex already. You know what I mean? Like before they even have sex, they have to talk about who's going to be playing what role. So they're like primed to talk about it. Whereas when in heterosexual relationships, there's no talking. It's just assumed that everyone knows what to do. And
it's scripted. It's scripted in a way that.
Yeah.
Well, I don't know if this was going to come up later, but I'm curious about this. Premature ejaculation in gay men. Historically, there's been a notion it's a lot less prevalent. And some of the data, if you look at how it depends how you ask the question. If you ask the question a certain way, it's similar across sexual orientations. If you ask the question differently, it's less. Gay men seem to be less bothered by premature ejaculation, according to some studies. They can be very profoundly bothered by absence of ejaculation altogether, much more so than in heterosexual couples, where oftentimes, again, invoking my spouse, a lot of heterosexual women are like, they'd be happy to have no ejaculation. That'd be fine for them. But gay men, gay relationships, ejaculation is very important. Not in all, of course, but in many. And so I guess I was wondering, from your perspective, my perspective, I have not seen very many gay patients with PE. I don't know if you've had different experiences.
Same. Yeah. I have not thought about that, but you're right.
Yeah, not a ton, right? And I guess kind of one thing you can ask is kind of the environment that you're in. Do men feel comfortable stating that they're gay? So San Francisco.
San Francisco, yeah, it's fine. Fine where I live. And where you live, too, in New York.
New York, right? New York, it's not a problem.
Miami's not a problem either.
Yeah, exactly.
Miami's not a problem either.
Yeah, and so it depends kind of where you're in and what region you're in. And so there certainly could be plenty of gay men coming in, premature ejaculation, but just don't feel comfortable admitting or talking about the fact that they're gay.
Yeah. Absolutely. And to your point, it was actually interesting, the meeting where I did our podcast with your wife, they had a comment about, they had a talk on ejaculation. And during that talk, someone raised their hand and said, I would be great if men never ejaculated. And I, sitting there as someone who takes care of men, was like a little bit like, oh my God. Like this, there's such a disparate, feeling about this. And I was like, it's so interesting that it was, and people were like cheering the question and like, yes. And I was like, wow. I was just sitting there like, observing, Well,
it's a fetishization of semen that many men of any orientation have, and I think a lot of men tell me they come in to see me by themselves, their partner's not there, so I'm like, I don't ejaculate, my partner hates it, she misses it so much. I'm like, I'm not sure I believe you. Did she say that to you, or are you assuming that?
Yeah.
There is data on this, interestingly. There was a study out of Germany about 10 years ago. It was 20-something-year-old German women, heterosexual. And it was interesting, they found that the majority of these, again, not representative of the world, but in this one subset of data we have, women generally appreciated their partner climaxing during penetration. A slight majority said that's that's a part of my experience and part of what I enjoy about it is my partner climaxing. Interestingly, there were some women who valued the actual semen, the actual ejaculate, but it was like less than 1 out of 6.
Yeah.
So by and large, women like their partner feeling pleasure. They like their partner orgasming for whatever combination of reasons. Semen itself, not so much a part of what is appealing. Again, differently when you're talking about men. You know, a man with a man, two people who probably fetishize semen together, it makes all the sense in the world that it matters more in that context than in a heterosexual.
I mean, I know that we've all seen guys who have lost either their volume or had that procedure done, and it has completely devastated their relationship with their partner, or because their own sexual experience has been compromised. And I think that's something that we don't talk about enough. But you know, living in Miami, a lot of guys are bothered by their semen volume if it does decrease or go away. So you know, it is something that, you know, until I really started practicing, I didn't have a grasp of how important it was to so many men.
Yeah, that's the principal reason for consultation for me. Many times I just want to talk about that. That's the only problem I have. And we spend time talking about it, and that's what we do.
I didn't either. I'm with you. Like, I didn't realize what a big deal it was, but now every time I prescribe a medication which can affect ejaculate volume, we spend time talking about it.
Absolutely.
But in residency, like, you would just hand out medication, and you'd be like, here you go, it's going to help your prostate, and you know, it would never be discussed. And I can just imagine how many men went home, had a change in their ejaculate volume, and thought something was wrong, but never brought it up. Right? They were like, oh, something's wrong, but I can't bring it up, and so yeah, it's definitely something that I think we should be talking about a little bit more.
Whenever I get the non-specific, patient did not tolerate this alpha blocker medicine. I know what you're talking about.
Yeah.
It wasn't dizziness and orthostasis. I know what happened, and that's why he didn't like it. That's why he's not taking it now.
Right, absolutely. Let's talk about medications for premature ejaculation. Right now, there's no on-label medications in the U.S. for premature ejaculation. What are you guys using, and how does it work?
I mean, typically, I will always start with a PDE5 inhibitor if I identify some component of erectile dysfunction, because like we've already talked about, a lot of these guys are trying to rush to the finish line because they're worried about losing their erection before they achieve orgasm during the sexual experience. So that there is some data showing that, you know, taking Cialis or Viagra can help. It can also reduce, you know, daily Cialis can reduce refractory period for some men. So which is great, especially in the premature ejaculation group where they can hopefully go again sooner. That's usually, in terms of medications, my go-to. Obviously, there's SSRIs, which we can all talk about. But, you know, there's a huge stigma on them. I think a lot of guys sometimes don't want to take them, understandably. So it's usually, I'll try a couple other things prior to getting to that point, unless the patient's really adamant of starting out with like a medication like that, which they usually are not.
I try not to be overly reductive of men's sexuality. It's easy to do, and many of us do this, and I do it too sometimes. And I agree with Justin that getting an erection that is hard and reliable and rigid, I am going to say it is not the end-all be-all, but it is really, really central to a lot of men's experience of sex. And I would say regardless of the presenting concern, you know, if there's any element of erectile dysfunction or any element that, boy, if I had more confidence or if I had more rigidity or if I was just more durable, I could work through this other issue of climaxing before I want to. So I'm aligned with you that I'm pretty liberal about PDE5 inhibitors like sildenafil or tadalafil, a daily dose or on demand, for these patients, but recognizing at the same time, it's not clear that we're treating premature ejaculation when we give those medicines. We're treating something else that is adjacent to and maybe a fix or part of a fix at least. And it's a very safe class of drugs. They've been around a long time, 28 years now since sildenafil came out. So it's something that I'm very comfortable prescribing to people, but acknowledging at the same time we're not treating the fundamental issue. As Justin says, SSRIs, several of them, paroxetine, fluoxetine, sertraline, several others have been approved. Not approved. They have had plenty of data behind them suggesting they can prolong ejaculation latency. But as Justin also says, there's a stigma. There's also some risk. These are safe drugs, but they're not risk-free. And they are antidepressants. They carry some of the baggage that goes along with that drug class, and they have some risks. Many people don't want to mess with them. They don't want to take them. Another thing that is currently considered first line in the management of premature ejaculation would be some sort of topical anesthetic. So the idea being to reduce sensitivity a little bit, not totally. Obviously, you don't want a numb penis. You don't want a numb partner, so you have to be judicious about the use of those things. But that is another thing that has data behind it to support its use. And again, just to be very clear, I misspoke earlier. I said the wrong word for 1 second there. None of these are formally approved by the US FDA for the treatment of premature ejaculation. They're available. A doctor can prescribe them, or in the case of anesthetics, you can just buy it over the counter, no prescription. But they have not yet been formally approved, nor probably will they ever be approved in this country. There was a short-acting SSRI known as duloxetine, which was approved in several other countries specifically for this indication of treating PE. Not approved in this country, probably never will be. I guess it was premature to approve it back in 2014 when it came out, and it didn't pass muster at that time.
Premature.
Very premature.
It was
too premature. It came out. It came too early.
Why didn't it get approved in the U.S.?
Well, it was unfortunate timing. It was not a dramatic effect. It did show comparable efficacy as an on-demand treatment for premature ejaculation. It was comparable efficacy, maybe not to paroxetine, which has the most ejaculation prolongation, but sufficient that it was clinically relevant compared to placebos. So it was a compelling enough study. I think certain medications in sex medicine have been approved with similar efficacy data. I think to some extent it was a problem of timing, because at exactly the time that these drugs were going up to the FDA, there was a crisis and an awareness of suicidality in young men taking SSRIs for depression. And that's something that we do know happens. That's on the label of SSRIs, that when someone initiates it, in some cases, if they're depressed, they get motivated enough that they can then take action to harm themselves in some way. So they have enough energy to do that, but they're not yet so much feeling better that they don't want to do that. So it's a crisis, it's a problem, and SSRI use has to be approached carefully, and it just happened to be very poor timing that this SSRI drug was looking for approval when people were very anxious about using SSRI drugs in young men, which is the target population for a drug of this nature for PE. So unfortunate timing. Again, this was a decade ago, so I don't think it's coming back. And it wasn't, when you look at long-term follow-up from other countries, it has been in use in Europe and some other countries around the world. The discontinuation rates are pretty high. So it hasn't really panned out despite clinical efficacy in studies. In real-world experience from outside of the U.S., it has not been a game changer, unfortunately.
Yeah, I think most of these options are not game changers, unfortunately. I mean, they give you some incremental benefit, and it can be very frustrating for patients. I think the other thing is sometimes, speaking about PDE5 inhibitors, I think sometimes people don't have the words to explain premature ejaculation, and they will come in and say, I have a problem with my erections. And so they will leave with a PDE5 inhibitor, but actually their erections are not the problem. And if they don't have any ED, it's not going to help. And I think that's really important, is if anyone watching really is like, this is resonating with you, make sure you say, I can't last long enough, or I'm having trouble, I'm ejaculating too soon would be the better way to say it. Because I think otherwise it can be misconstrued by the doctor. It can be, and then you will leave with something that doesn't help you.
Oh, I had a patient who said he was referred to me for ED, and I said, I get ED. I said, well, when does the ED happen? It's like, well, after I ejaculate, my erection goes away. I was like, okay, that's natural. And he didn't know that, and he needed to be educated, and obviously no one had ever told him that that was normal. Mm-hmm. And it was not even so much a case of premature ejaculation. It was just he had a refractory period. Erections goes away after you ejaculate, and that refractory period gets longer as you get older, and that's kind of natural to some extent. And it was a good conversation.
Yeah, there's always a couple patients I see a year who are coming in with erectile dysfunction, and they'd say, I can't go round 2 as soon as I wanted to anymore, or round 3. And I'm like, God bless, man. But, it's not erectile dysfunction. You're right. And I think that there is this misunderstanding there. You're able to perform, but unfortunately, as we get older, as you said, sometimes that recovery period can take a little bit longer. Now, is there theoretically, potentially things we can do? For sure. Is it going to work for everyone? Probably not. And I think, counseling and education is so important in those situations.
Yeah, absolutely. What about new medications that are currently in trials? I think KH001 is one that's currently in trials. Do you know anything about that yet?
I'm kind of cloistered away from that due to some roles I have with AUA and guidelines that are being prepared, so I'm not really allowed to participate directly to see any of those data. And even if I was, I wouldn't discuss them, because these are things that are usually pretty much under wraps. Obviously, as I said, there is no approved agent for PE, and if there were to be one that had good efficacy data, good safety data, tolerable dosing profile, I'd be all for it. I'll be eager to see the data on that. I'll be eager to critique it and look at it and sort it out. But I will be more than pleased if there were ever an agent that was shown to be efficacious and safe for this condition, but nothing currently, anytime in the near term for sure, that I'm aware of.
Dr. Dubin, you did a study looking at online the online marketplace for these online ejaculation programs. What did you find?
TikTok, Instagram has been kind of a toxic place for men's health for the last, I'd say, since COVID, really, where that was the turning point for a lot of people, where they really started to get their health education and their health information online. Now we're obviously going more towards AI, but still everyone's online. They're going through social media. I think at least 50% of Americans have purchased a product or some kind of, coaching at some point in their lives. I'm guilty of it. When I was in med school, I bought raspberry ketones. I thought it was going to make me skinnier. It did not actually work. And I was in med school. So obviously
you were
it can get you.
enough,
It can get you, right? So what we did is we looked at online and men's health topics on TikTok and Instagram. We graded them we looked at the popularity of the topics. We looked at, who was giving the information, whether they were a medical professional, whether they were a company, whether they were selling things, and how accurate was the information. And overall, the data was terrible. I mean, the data showed that the majority of online information on social media is not accurate. And a lot of that is because most of it is not given by medical professionals. I would say about 10% of them were physicians, maybe about 20% were healthcare providers in some sort of setting. So when you have a lot of people going online telling you things that you want to hear or things that you are insecure about to get fixed, you really have to understand that these people are probably selling you a product. They're probably selling you some kind of approach that really isn't data driven, that really doesn't work. And fortunately, we have physicians like yourself who are online and providing real, good, accurate information. And what we have to do is continue to encourage people to go to good sources. And when you're going online, I think you always have to ask yourself questions. First is, what do I want to learn about? Do I want to learn about this disease state? Do I want to learn about, options for treating these things? And then two is what's my goal of this learning? Am I going to try to reach out to someone to make a visit for a doctor? Am I trying to purchase a product? Am I just trying to learn? And then three is who am I getting this information from, right? What's their background? Are they a healthcare provider? Are they a specialist in this? Or are they just some guy who says one click and you can get this from the comfort of your home? And, I think when you take a step back and you look at it from that perspective, it becomes clear. But like we said, it's very hard when you're kind of embarrassed. You have this stigma of shame around yourself and you don't want to talk to anyone about it. And you have someone there who's kind of promising you the world at your fingertips. And it's very easy for a lot of men to be taken advantage of in the space, more so than ever before. So, you really have to take a step back because it's so easy to get lost in all this stuff.
Yeah. It's a good time, but it's also the worst of times.
Yes.
You can find great information. I mean, I learn stuff all the time on social media that's actually helpful, but at the same time, it's very easy to get duped, even for us, right? Someone can, actually, my husband was just telling me, oh, I was watching this guy and he was wearing scrubs, so I just assumed he was a healthcare professional, and then I went back and looked and realized, oh, he's not.
Yeah, they're selling you a pillow, but he's wearing scrubs. On TikTok, they have all these just 18-year-old guys wearing scrubs, and it's just, oh, this guy might be oh no, just buy this supplement for your cortisol spiking, which truly makes no sense. But to your point, I think it's really become so difficult to understand who's a good player or a bad player, because we're at a point where, I see a video and I'm okay, I'm trying to learn about a GLP-1, but I don't know if this person who says they're a doctor actually knows the stuff. So I'll often text a specialist that I know is good information, a video, I go, is this real? Is this accurate? And oftentimes their answer, no, it's not real. And so if I, as a physician who knows data, cannot identify a super subspecialist, whether that data is good, I think it's impossible for the average American or average person to identify, because the truth is medicine is great because we are so subspecialized now, but it's impossible for me to understand what a nephrologist does, what a I don't have all the knowledge in my brain. And so if it's hard for me to distinguish what makes a good specialized physician in one other field, it's going to be impossible for someone else.
Well, and with AI now, there are so many deep fakes of me. And in fact, like they will, and we get phone calls about it, they will actually message people on WhatsApp. They will sell supplements to them, and they will say, call my clinic. And so they will call my clinic, and they're like, where are the supplements? And then my friend is like, what? What do you mean? We don't do that. That's not us. And it's happening all over the place. And they're preying on older people. Like, so they're on like Facebook preying on older people who don't know, and they see my face and they're like, oh, I follow her. Like, she's great. And they're using that. And so we're still figuring out how to, like, the platforms help a little bit, but they're still figuring it out. So it's like, how do you really get all this stuff down? And there are some services that help, but it's still like, we're still in the process of figuring it all out. It's not seamless. And so it's happening to anyone who has a platform, which is really kind of scary, because now you have to differentiate, is that really her or is that AI her? You know? It's
No,
crazy.
I play a game with my grandpa who, he's on Facebook. So he'll text me probably a couple times a week a video about men's health, like that's going to make your penis larger. It's going to shrink your prostate. It's going to do something crazy, improve your testosterone, cure your dementia risk. And he just says bullshit or not bullshit. And he knows it's bullshit, but he sends me the videos. It's crazy what's out there. And if I'm an older person, I can see how I can get tricked into this stuff. It's really
we can
upsetting.
get tricked into it now.
Absolutely.
Like I've seen my friends, and I'm like, is that really them, or is that an AI version of them? You know? And I'm like, I don't know. So it's crazy. Let's play a little game. We're going to say true or false. Anyone can answer. Multiple rounds of masturbation before sex will help you last longer.
Maybe.
True. If I have to give a one-word answer,
Yeah.
it's more
Okay.
nuanced than that, of course, but true. Assume you can get an erection back when you're with your partner. That's the caveat.
That's
there.
what I was going to say, like maybe, because if your refractory period, which we already discussed, is quite long, and if you masturbate like 3 times, you might have just worn yourself out for the day. So you could actually create worse problem because you won't even be able to get an erection.
You won't
in the
even
first
get one.
place. Yeah.
Yeah. Yeah. Thick condoms or multiple condoms help you last longer.
I would say false because one's enough. I would say, like, I don't think you should ever be stacking condoms on top.
Well, that's bad from the public health perspective because they'll break.
Yeah.
Yes.
It's probably worse to stack because they're going to rub and break it, and so then you'll have no condom, essentially, especially if safer sex is necessary. That's a bad idea in general. Condoms, they do reduce sensitivity. I would say conceptually maybe they would be sufficient that they would help. They're kind of like the local anesthetic in that regard.
Mm-hmm.
So if someone wanted to experiment with that, not much downside, but not a lot of data either.
As long as they do it with one condom and kind of using good condom practice.
Yeah. It's not surefire, but it might help.
Yeah.
Yeah, but the problem is people in a monogamous relationship really don't want to use condoms.
But nobody
That's
wants to
what
use
it
condoms.
is. Yes,
I don't
correct.
think.
That's-
Nobody.
that's
We
fact.
use them, but nobody ever likes a condom. I don't think.
Yeah. Alcohol helps you last longer.
I guess it could be true. I mean, like it's difficult to say.
Well, these are tough true-false questions, Rena, because
That's the
ultimately
point.
this is
They're
where we So this is again, I would say, true, and once again, kind of like the multiple rounds of masturbation or the thick condom. You could take it to a point where you drink enough alcohol where all of a sudden now you're getting no erection. And I would say that you're kind of suppressing, if you're drinking a drink and your anxiety falls away, you're less concerned, you're more relaxed. It could be a positive. If you drink too many, tough to get an erection, defeated yourself.
Yeah, the disinhibition, right, around the alcohol piece might play against actually helping control ejaculation as well. And so it might be a little bit like helps with anxiety potentially, but you might not, you lose kind of a sense of your body a bit.
And I guess my bigger concern is that if you start to rely on alcohol for a sexual encounter, alcohol in particular concerns me because of its potential for abuse and negative effects.
Yeah, no
across the
doctor's
board.
ever going to recommend having a couple of drinks before having sex.
They used to, I think, for women especially. It's like, just have a drink,
yeah.
you'll be fine. I think that's more in the female space. Like, have a drink, just relax.
So crazy.
But that's
As
obviously
they were
not-
smoking a cigarette, though.
Yeah,
and-
pretty much.
Outside the OR.
Yeah.
Premature ejaculation is just about being inexperienced.
False.
That's absolutely false. We all know that one.
Yeah, no discussion.
Yeah.
False.
Yeah. Great.
We agreed there on that one.
Circumcision status affects premature ejaculation risk. So there is some data on like frenulum length and premature ejaculation. Is that right?
Again, you'll find a study to support almost anything. Once again, invoking my wife, you can find a study that will support whatever thing you want to believe in the world. So I'm sure that there is probably a study somewhere that says that some element of it. But the best data on this, we highlighted it in our guideline on disorders of ejaculation for AUA, was that in aggregate, overall, across the world, all studies that have been done on the topic have not demonstrated any consistent effect of circumcision status on latency time. Now, there may be individual men who have a frenulum issue, who have a phimosis, a tight foreskin issue, some other issue in play for them, where on a case-by-case basis, being circumcised may make a difference. But I would not say that people can legitimately claim that mommy had me circumcised and that's why I have this problem now, or saying that's the circumcision that did it. You'll never be able to prove that one way or the other, but my sense from the data is that that is not the case. The circumcision did not cause PE.
And there's been really good studies in the last few years showing that sensation, before, after is pretty much the same. And listen, I do a lot of circumcisions, and I tell a lot of people who ask me, like, does circumcision cause these issues? I say, listen, if anyone was going to, people are very serious about their penises. And if it was to be something that really compromised their sexual health, I would be long gone, right? And I do enough circumcisions where if someone came back to me unhappy, I would know. And I've never had an issue in terms of sexual performance being impacted after a circumcision. And we do it in adults, right? Like, I'm not talking about a child. And, there's data also showing before and after sensation was the same. So, I think that there's obviously a lot of controversy right now, a lot online for sure, about these ideas, and there's just really no data to support it. And if it was a problem, I would be long gone, probably. Just the fact that I'm still here, I think it says something about it.
Yeah, absolutely. Is there any interesting emerging research in this space that you guys are excited about?
You had mentioned a therapy that's under investigation, and obviously you had invoked that electromagnet thing on the perineum. There's Botox was investigated. It was a big deal from a researcher, a friend of mine named Egi Sarafolu in Istanbul. He was, touting that as a potential treatment. It's kind of faded. I haven't heard from him about it lately, so I'm not sure that's really panned out. There were notions of certain other oral medications that could be used to treat this, drugs that work on different neurotransmitters other than serotonin. Those unfortunately didn't work out either. There was some initial excitement, some initial exciting studies, but when the follow-up data were done in larger controlled studies of a drug that would basically alter neurotransmitters in a way that was anti-ejaculation, slow these things down, it didn't really work out. So it's not the most popular space when you talk about things that, are of interest to commercial entities who can make some money from this, and you think about how expensive it is to get a drug to market and to pass the FDA. I think there's not a lot of appetite because I think the business case just isn't there. So as far as I'm aware, there's a few exceptions. There are some things that are under investigation that may or may not pan out. But it's not a big thing. It's not a major thing that there's major companies pushing for it. It's usually small startup kind of things that are hoping for a real home run of something that will make a difference. So there's stuff on the horizon, very preliminary though.
Yeah, and I guess, kind of from some psychologist, right, and looking at the data and the presentations at AUA, at Sexual Medicine Society, I don't know that there's even a mechanism that we're really excited about, right? Like, this is the mechanism, and we have kind of a number of potential ways to kind of attack that mechanism. I don't know if that's true or not, Alan, but there's nothing that seems to jump out kind of from what I've heard, that there's even like this is the path we really need to take. This is the mechanism that we're really excited about.
Well, I think some of it's centered, again, coming back to those fundamental neurotransmitters. Serotonin we know about. We have drugs that do that. We're never going to see another duloxetine attempt. Could you modify oxytocin? Could you modify dopamine? And again, some of the things that have been investigated have been trying to modulate those. So in some cases, suppressing those receptors, because oxytocin and dopamine are generally pro-ejaculation, pro-orgasm. And those are the drugs I was talking about that didn't, unfortunately, quite pass muster. So those are the mechanisms that haven't really panned out, unfortunately. And I think it gets at the notion that ejaculation just isn't well understood.
It's complex.
I mean, we know a lot about how the penis gets erect. I mean, the mechanics of that, the nerves that mediate it, we understand it pretty well. and because of that, we have a lot of tools to modify erections. Ejaculation involves so many central nervous system factors, in the brain and the spinal cord, everywhere else, and our ability to intervene on those cleanly without causing many potential side effects is more limited. So I think you're right. There's fewer targets.
Yeah, I think also just as we've had this conversation, it's not just one thing sometimes, right? So, one magic pill to cure your ejaculatory issues is probably never going to be the way it goes. Biopsychosocial is so important, especially in the complexities of sexual health for every aspect, whether it's your erections, your ejaculation, your orgasm, which are separate, which is a whole other story. So I think it is difficult to be like, hey, this one thing's going to fix all the problems in the space, because it's not. Some people will never, I've helped people with correcting their hormone levels. I've helped people with just pelvic floor physical therapy, or just, talking to someone, a therapist or a psychologist. Does it help everyone every time? The answer is no. So it is so individualized that, one size doesn't fit all.
Yeah, absolutely. So as we sort of round out the discussion, I'd love to hear from each of you what you would tell the man suffering from premature ejaculation as they leave this conversation.
I'll start. So I think that there's a lot of different treatments out there. We've discussed a lot of the treatments. There's a lot of things that we can assess. And I think the big problem is, we can't help you if you don't come in. So the biggest step for anyone who's struggling, with sexual health, whether it's your erections, your ejaculation, you just need to make the biggest step and invest in yourself and come talk to a doctor, because there are things we can do. There's ways that we can address it. And a lot of that is, a conversation and figuring out what may work for you and what's best for you. So I really encourage people, because, premature ejaculation, as we've already established, is one of those things that people just don't really talk about or are embarrassed to talk about, more than their erections oftentimes. And, 50% of guys have ED, about, 20 to 30% of men with premature ejaculation. There's a large population that are not addressing these concerns if they have them. So come on in, because we can help you.
Mm-hmm.
Mm-hmm. So just to piggyback on that, so come on in. One is, you're not alone, right? There's other men who are out there who are struggling with premature ejaculation for sure. And what happens, right, with the anxiety is that the anxiety leads to avoidance. And so if you're anxious in a sexual situation, it potentially could lead to you trying to avoid or trying, everything you can not to get in that situation, because it's anxiety provoking. I think for men, they think the worst thing that can happen is that they're in a sexual situation and they're embarrassed to some extent, whether it's ejaculating too quickly or whether it's with erections. The biggest risk actually is that they don't seek treatment or they even stop. And so this notion of coming in is really important. And kind of on that, there's ways that we can help. And so, and it may be a springboard for you and the relationship that you're in right now to really talk about some of the aspects of sexuality and really improve the sexual relationship, not only just with ejaculation, but the whole sexual relationship and how to improve it with you and your partner.
Mm-hmm.
I would say that agree 100% with Justin and Chris both. And I would say the first conversation probably needs to be with your partners. Talk about what's going on. Open up the conversation. It's difficult. It's hard to talk about sex, even with our intimate partners, spouses, girlfriends, boyfriends, whatever it is. But it's a really critical part, because, we can't necessarily help you if you haven't had that conversation at first. In terms of locating us, honest truth, most doctors don't want to talk about sex. And they especially don't want to talk about premature ejaculation. Mm-hmm. So you're not necessarily going to be able to find again, no offense to primary care doctors. They have so much on their plate. They're probably not going to have the bandwidth to go deep on this topic with a patient. So what they need to do is find one of us, and I think ways to do that would be for our organization, the Sexual Medicine Society of North America. It runs a patient-facing website. The American Association of Sex Educators, Counselors, and Therapists, Society for Sex Therapy and Research. These are organizations that are dedicated to sexual wellness, and they're great entry points, whichever way you want to start, getting plugged in with people who are going to be able to talk to you about this and know about it and can offer the options that exist. So I think identifying us, having the conversation with the partner. When you come in, if your partner can come along, fantastic. I know it's not practical in many cases, but it's always a positive. When I see the partner there, I know that this is a couple that's engaged. It's not just a man looking for something. It's a couple that wants to work on this couple's disease, this couple, not disease, couple's condition, where they are working on it together. And I would say approaching that conversation, some things I do a lot of medical student education, and one of the things we teach our medical students when you're eliciting the history, and patients can do this on their own ahead of time, come in with your ideas. Tell us why you think this is happening. Was there something that changed? Was there something that's intrinsic? Did there something that you did or was done to you? Your idea about why it happened. What are your concerns? My partner's going to leave me. My partner's not satisfied. I'm not a man. I'm not this. And again, conceptualizing what are the concerns that you're bringing to that appointment and knowing those ahead of time. And lastly, setting up the expectation. What do you want? What is the best outcome? And we may not achieve best outcome. We'll achieve the optimal, best we can outcome. But having a clear idea of what someone wants, and I think something that is especially important for these patients who are concerned about latency of ejaculation, I last 30 seconds, I want to last 10 minutes. Probably not going to happen, okay? Most of these drugs that we use for PE, they do what we call a fold change. So it doubles, it triples, it quadruples in some cases. That means, if you think about it, even the best case scenario, what you're looking at is you go from 30 seconds to 2 minutes. That's a substantial increase. It may not be what you see in the movies. It may not be what you're seeing online when you watch your porn. But it's an improvement, and setting reasonable expectations. You can come in with your pie in the sky expectations and we can try to meet those, but understanding that the goal is, again, not ultimately some stopwatch mediated metric of success. It's having an enjoyable, pleasurable, intimate connection, or just pure physical pleasure, depending on who you're with and what you're looking for from that sexual encounter. Something that satisfies you and gives you what you need, not some stopwatch based metric.
Absolutely. And I would just say that, this, because there's no like one pill fits all, that there's some trial and error that goes along with this. And you have to be open to that. And we want to help you. And, we're working with the limits of what we have available to us to help you, but we're going to do our darndest, but you got to come in. And so we can really get you through that, because there's no point in suffering in silence. Yeah. Well, thank you guys so much. Where can people learn more about each of you?
Well, I had mentioned, globally talking about our society, the Sexual Medicine Society of North America, I would steer people to that. We have a website called sexhealthmatters.org, all one word, .org. There's other organizations like the ISSM, the International Society for Sexual Medicine, and the sex therapy organizations that I mentioned earlier. I'm kind of a social media Luddite, to be honest with you. I don't have any professional social media profiles. I don't have any I have one personal one, in fact, so I'm not really on social media to any extent. I do work at UCSF, University of California, San Francisco. That's where I see patients, and I have a partial appointment at our San Francisco General Hospital. So I have a website there. You can look me up at UCSF. I have a profile, I think, on some of our organizational websites, but not a lot of social media presence. I leave that to my wife. She's the social media queen, or at least a aspirant to queen.
She's great.
She is great.
Yeah, I don't have a lot of social media presence either. I'm a psychologist. I work primarily with cancer patients, actually, and so I'm now at Indiana University in the cancer center there. But if you're at Indiana and you're a cancer patient, you can certainly look me up for sure.
I'm in South Florida. I'm at Baptist Health in Miami. So I'm caring for patients in South Florida as the director of men's health there. I also have some socials at Justin Dubin, MD. You can find me across all social media platforms. And I also have a podcast, Man Up, Doctor's Guide to Men's Health, which you can find on all podcasting platforms. We've had Rena on before, and it's always a pleasure to be with all of you guys. Thank you.
Yeah. Thank you guys so much.
Thank you for
Thank
the
you.
invitation.
Yeah,
Rena.
great to be here. Thank you.
Awesome. Thank you guys so much for joining me on today's episode of the Rena Malik MD podcast. If you like the podcast, do me a solid favor. Go wherever you're listening or watching this and subscribe to the podcast. It's a zero-cost way to support, and it really helps us tremendously. And as always, remember to take care of yourself, because you're worth it.